Hey guys, and welcome to the ALiEM-Annals Global EM Journal Club today. And we are so excited to be hosting a pretty global emergency medicine journal club on the topic of Press Ganey and patient satisfaction. Specifically, there's a paper by Taylor et al., actually Taylor Schwartz et al., called Lack of Association Between Press Ganey, Emergency Department Patient Satisfaction Scores, and Emergency Department Administration of Analgesic Medications. And here we have today an all-star panel who I wanted to introduce to you first. We have here Taylor, kind of the star of the show today, Taylor Schwartz, who is a second-year med student from Brown University. Hey there,
Hi.
thanks for joining. We have next Kavita, who is from University of Massachusetts. She's the Medical Toxicology Fellowship Director, who is also an author on the paper. Hello, thanks for joining.
Thanks for having us, Michelle.
We have here Justin Hensley, who is an assistant professor. I just accidentally promoted you. Assistant professor of emergency medicine at Texas A&M at Corpus Christi. We have here Lauren Westofer from Bay State Medical Center. She's an EM resident. And off screen, you're going to see a beautiful picture of Sam Shake, who is an EM resident over in Detroit, Wayne State. And so here we have our all-star panel, and I wanted to kind of start this all off with a question to Taylor and Kavita about, can you tell us or share with us things that are not in the paper, specifically, how did this study come about, and why did you decide to look at this question?
Well, Kavita has a lot of expertise in opioid prescribing and practices surrounding opioid prescribing, and she really inspired me and made me interested as a college student, actually. We've been working on this for 3 years together, and we were really concerned that physicians were changing their opioid prescribing practices based on concerns about Press Ganey satisfaction scores.
And even before meeting Taylor, what I was finding at different opioid prescribing conferences that we were hosting is that the one comment that came up invariably when we spoke with particularly emergency physicians in community practice was that when we asked them to really be conscientious about their prescribing of oxycodone and hydrocodone in acute exacerbations of chronic pain, the one comment we heard over and over and over again was, how is this going to affect my patient satisfaction score? And in a lot of these shops, what we find is that bonus compensation, which can be up to 20 or 30% of their base salary, is linked to patient satisfaction scores. And the industry standard, as Michelle has called it on the blog, or sort of the yardstick by which we are all measured in many of these shops, is Press Ganey.
Well, I think that is a great segue into Lauren's segment here, which is, just summarize the paper for us so that we're all on the same page.
Absolutely, and that's a really excellent insight to have into this paper. And I think it's a question that a lot of people have, or the assumption that a lot of people have regarding patient satisfaction and opioid prescriptions. So in this paper, what y'all did was essentially look at information from 2 academic urban emergency departments in New England. And specifically, y'all looked at the data from the Press Ganey patient satisfaction surveys and the electronic medical record reviews for the patients that were discharged from emergency departments between October 2009 and September 2011. And the overall primary outcome was the Press Ganey Emergency Department patient satisfaction scores. And there was like a secondary data analysis of that data. And what they did is they found no association between analgesics prescribed in the emergency department and the patient satisfaction scores measured on that Press Ganey instrument. And I thought that was pretty intriguing information, and contrary to what a lot of people, I think, would think. And looking at, it was, I think, about a little over 404,000 visits from the EDs. The total surveys were like 4,749 surveys that were completed. So it was data from just under 5,000 Press Ganey scores.
Yeah, that's right. And so specifically, some of the things that we did were we couldn't look at all of the Press Ganey scores that were returned because our focus was on analgesia. So we had to eliminate those surveys that were filled out by proxy. And I think that in total we had over 6,000 surveys that were returned during that period, but we were looking for people who received analgesics to be able to comment on their care and their satisfaction. So that kind of brought us to to our total. This study, one of the things that we hear about a lot when we undertook this study were the limitations of the Press-Ganey survey. And I think there's a lot of questions that are out there about is Press-Ganey the right methodology for studying patient satisfaction in the emergency department? And looking at the Twitter feed, looking at the blog, that's one of the primary concerns people have when they look at our work. I think we've addressed the why. It really is that, it's just most commonly used. But Taylor, if you were going to break down like some of the acknowledged limitations of this study, I think that would be a good jumping off point as well.
Okay, so Press-Ganey, and I'll be the first to admit this, has a lot of limitations. However, you can't talk about patient satisfaction without talking about Press-Ganey scores, because that's the industry standard we're using to evaluate our emergency docs. So the limitations, though, to enumerate them, we only looked at patients who were discharged from the ED, so inpatients weren't included. These patients might have been sicker and have different experiences. We only included patients, as Kavita said, that filled out the survey themselves. So we're missing out on a lot of marginalized people, those who are illiterate, those who are homeless, those who are blind, anyone who wasn't able to take the survey themselves, anyone who can't receive mail and send mail. Their voices are not heard in these results.
These are all wonderful points about Press-Ganey, and I thought Kavita actually asked a great question on Twitter, which no one actually could answer, which was, if you had an unlimited number of funds and time and resources, what would be your standard? And no one had a good answer, and so you're kind of stuck with what is the industry standard, which is the Press-Ganey. But sorry to butt in. But let's move on to the first question. I think Justin had a question for you guys, who is currently on mute.
Well, off mute now. Absolutely. And so, the study evaluated the association between analgesics provided in the emergency department and subsequent patient satisfaction scores. Do you think this analgesia in the department can be extrapolated to satisfaction because of analgesic prescriptions dispensed at discharge from the emergency department?
I think that's a great question, and I think that's sort of the burning question with all of this is when we talk about responsible opioid prescribing, we're not usually talking about what patients receive in the emergency department. We're talking about what we send them home with. I actually thought, as I think Taylor did as well, that we would see a linear relationship between how much opioid analgesic patients received and their overall satisfaction score, as well as the specific question on the survey that asks about how well your pain is controlled. This, I think, is one of the most important elements for people to understand about Press-Ganey is that when you look at the survey, it doesn't actually contain questions about a wide variety of disease processes. It's not asking about how accurately your doctor diagnosed you. It's asking about the cleanliness of your environment, how long your wait time was, communication with nurses and physicians. And then there's a question that says specifically, how well was your pain controlled, which really makes analgesia relevant to this question of satisfaction scores. When we had originally conceived the study, we were looking to round this out with both in ED opioid administration as well as the discharge prescriptions. But there are certain concerns that we have in terms of using that discharge prescription data. The first is that technically Press-Ganey surveys your experience in the emergency department. And we all understand that this is returned on like a 2 to 4 week delay in many cases, if not longer. So there are certainly other elements that affect your perception of that experience. The second thing is that we don't actually know what percentage of our patients fill these prescriptions and how many of the medications they take. So it just sort of led to this question of whether or not we could draw that sort of linear relationship that we were able to with morphine equivalents in the emergency department. And then third is sort of practical consideration, which is just something for everybody who conducts research dependent on an EMR, is that during the time that we started our study, our hospital actually discontinued its relationship with one of the vendors who provided our discharge instructions. They would have been able to write the code that would allow us to perform an electronic query of the discharge instructions, but they were no longer able to deploy their code on our servers because we no longer had a relationship. So in order to do this, it would have taken, hundreds of hours potentially in order to go through and review all of these discharge instructions by hand. And getting clean data from that, I think, would have been a problem. So it was certainly one of our goals, but for these different reasons, we didn't actually go that far. And I can explain a little bit more about that. So I can't give you a scientific answer, but I can tell you what I think. I don't actually think that there's going to be a relationship between discharge opioids and Press-Ganey scores. And the reason that I say that is that I still believe that the opioid abuser or opioid fixated population is relatively small. So trying to hit that target with, the randomization that Press-Ganey uses and then the poor response rate, I don't think that's where we see it. What I suspect is that issues with discharge opioids come up in complaints. And we've seen that very frequently in our emergency departments, is that I don't think that in the general population, the folks who are unhappy with their opioid prescriptions are going to bring your Press-Ganey score down, but I think that your department is potentially going to spend a lot of time responding to complaints, and depending on the tack your administration takes with that, whether they're supportive or of their docs, or whether they're supportive of driving their satisfaction by giving patients what they want, that's going to set the tone for opioid prescribing in your group.
Certainly, I agree. I mean, the idea is if you think they have a painful enough condition that you're giving them analgesics in the department, most of those people, maybe not 100%, but most of those people are probably getting home with prescriptions. And so I don't think you're going to have a wildly different data set for those two groups of people. There may be a few outliers here and there, but in general, if they got pain meds in the department, unless it was a condition that's resolved in the department, which is pretty rare, they go home with pain medicines. And so I think you probably picked up most of those people.
I hope so.
Lauren, you got us a follow-up question to that?
I do, and it's something that I think we all kind of think about, and it's that, so we talk about a lot about pain and it playing a role in patient satisfaction, or at least, there's a lot of talk about oligoanalgesia. So based on your clinical experience, and I mean, I guess you have a lot of large data experience here with this paper, do you think that pain control is the largest component of satisfaction, or is it like just a pretty small player, or what other things should we be focusing on as part of the patient experience that can actually affect patient satisfaction?
Taylor, you want to start?
Sure. So we know that the majority of ED visits are due to painful conditions. So I do feel that pain plays a huge role in why patients present and what they're looking for from their visit. I always ask my patients as a second-year medical student, what are your goals of this visit? And I hear pain control, and in most of when I'm at my ED doctoring site. I also think that shortening the stay in the emergency department is one of the most important things, but obviously as an individual clinician, this is a more systems level problem. But we do know that shorter lengths of stay can also help improve satisfaction.
I think this is one of the most puzzling parts of the patient satisfaction literature, is that you won't necessarily see the same trends depending on which study population is being examined and what your outcome measures are. So, for example, there was a study that was sort of widely quoted talking about increasing Press-Ganey satisfaction scores being associated with increased mortality. At the same time, when you looked at Press-Ganey scores among patients who had had MIs, this was the same year, I think it was 2010, they reported that higher satisfaction was associated with improved survival. There are so many pieces that I think just define the individual populations, and what we found when we had sort of asked for the data for our institution is that Press-Ganey allows you to do a data analysis within your institution. So you can have your data, you can analyze your data. I think it gets a little more complicated when you try to set up a multi-site study. The one sort of most generalizable predictor of patient satisfaction, though, that we've seen across these studies is wait time. It really is sort of either perceived wait time, actual wait time, or time to physician. and the rest, whether it's patient expectations, physician-nurse communication, sometimes you'll see those in, sometimes you'll see those out. And so I think that anything that we can do to facilitate rapid conversations with our patients, whether they survive or whether they surround opioid analgesia or other causes, that's probably the greatest driver of patient satisfaction that we know of.
And I think that a lot of that came up in the Twitter discussion too, when people were talking about, well, maybe it's not opioids, it's the discussion around them or the expectation or the conversations that we have, and people may not be educated about alternatives. So I think I agree with y'all.
I agree. And when it comes to the patient encounter, that kind of you come out of the room knowing that you kind of had a negative encounter. It's one of three things usually. It's they come in expecting kind of an unindicated exam, radiographic procedure, MRIs, CTs of their child's head, that kind of thing. Unindicated medications, either antibiotics or opioids. And I don't know that there's a big difference between those two in their satisfaction. Or because we're the county hospital, people who are sent to us for surgical procedures that I'm then not going to arrange for them on an emergent basis. But even though those stick in your mind, they're an incredibly small percent of the patients I see in a given day. And the vast majority of people are there because they're hurt or whatever, and you're taking care of them, and you're not really having that antagonistic nature of an experience with them.
And one of my colleagues, Matt Zuckerman, he really likes to talk about the fact that responsible opioid prescribing sometimes gives us an excuse to stop caring for patients. And what we found personally is that when these conversations really come from a place of care, when you're saying, I'm concerned that opioids might be dangerous to you, might be harmful to you, might prolong your experience with this. I'm worried about the fact that you're starting to show these addictive behaviors. I feel like you get a lot less pushback, because how can you argue with somebody and be like, you care too much about me? It's just it's different than being dismissive. It's different than failing to validate patients' concerns, to provide follow-up, to provide opioid analgesic alternatives. And I think that the communication piece of this we can certainly work on, and I think that the goal of decreasing inappropriate opioid analgesia doesn't mean that we shouldn't provide pain control for our patients, and we shouldn't validate suffering and treat these patients with great compassion.
I think the results of our study are exciting because physicians can potentially give drugs as they say needed based on clinical factors, based on patient factors, and this is still compassionate, patient-centered care. We're still doing what's best in the interest of our patient, and that's liberating. I'm excited about those results.
I think so too, Taylor. I think it's sort of empowering, because the problem is we all, and particularly if you're in a protected environment, we all think that the moral imperative to provide to provide patient care is going to trump financial concerns. It's going to trump administrative concerns. But as Zach mentioned on the blog, that's an easier position to take when you have no compensation or job security actually attached to that. And I'd just like to point out that in emergency medicine, I think that we're so sheltered from this. All you have to do is look at your doctor's health grades, something that follows them around, like this online report card, like Yelp, for doctors. When you look at health grades, you realize that the primary care physicians and the specialists bear a much greater burden in terms of responsible opioid prescribing than we do in the EDs.
No, that's so well said. And, there was actually a comment on the blog from someone outside of the U.S. that says, this is so America. What is going on with these scores, right? And they brought up a good point. They're like, why do you need these scores? And why do we need these scores? Why do you need a single metric out there? I think feedback is great. I think patient satisfaction in the end is all about feedback and hearing back from the patients, because you want that from an educational standpoint. You want to get better. But why do we have to lump it all into a single score? It's kind of mind-boggling to me, putting all these factors together. But these are all great points, and I kind of wanted to move on to question number 3, if that's okay. I think this one is, whose question is this? Justin's, you're up.
Off mute. Alrighty. And we sort of started to brush the surfaces at the beginning. You only studied the patients who returned the survey because you can't really. That was the whole point of the study, was to look at the survey results. Do you think that group differs from the others, and how might that be? And what might you and Taylor have done, given that you, again, had the treatment data on all the patients, to explore the potential for any response bias?
So as we touched on a little bit, we think patients who responded were probably healthier. They probably had more extreme experiences, although we can't prove that using the data available to us. It's commonly believed that those who actually bother to take the time to fill out a survey and send it in had a really good experience or a really bad experience. So there's that issue. So given that we had data on all of the opioids and analgesics and medications administered during ED stays, how could we have explored the potential for response bias? Did you have any specific thoughts on this, Kavita?
I mean, I think that if you were able to fund this with $1 million, the way that you could evaluate something like this, or if you had your big R01 and you had your research apparatus in place, because I think that's what it would take to get this non-responsive population studied well. The way that I would go about doing something like this is I would actually survey patients about their satisfaction with the discharge prior to them receiving their discharge prescriptions. And that way you would be able to get all comers before they actually knew what their opioid prescription would be at discharge. And then you would need to either perform your own follow-up, or because you get account numbers with Press Ganey, so you can follow this, you'd be able in a retrospective fashion to link their Press Ganey score to the original information. Again, I think that would be a pretty aggressive approach to getting sort of gold standard patient satisfaction information and comparing it with Press Ganey. But really, because we don't know the nature of the randomization, we'd be talking about performing that for the percentage of 400,000 patients that does not get admitted. And there are probably more feasible mechanisms out there, but I think in terms of the outlay of effort in order to do this well, it would be pretty substantial.
Yes. And we did look at amount of opioids received, amount of morphine equivalents received in a linear fashion. There are problematic aspects to doing further research with that outcome measure, because different amount of opioids affects each person so differently based on their perception of pain, their weight, their height, their history of opioid use or misuse, and those things are really hard to quantify even with the best abstractors out there.
Sure, absolutely, and you're at least spot on with the understanding of surveys that I think all of us get. We get the ability to go to hotels or restaurants or whatever, and the only places that you survey are the places that did a really good job or were so terrible that you think you need to warn all your friends about online. And I mean, if you give everybody all threes, that just means you were present. Surveys at the end of conference even. And I don't disagree with that statement. One of the things that we were looking at was, of the people who returned the survey, about half got analgesics. And is that also about the same rate in your ED as a whole, or were we able to pull that data out? I didn't see anything in the paper about that.
I don't think that we ever looked at that specifically to see how our non-opioid analgesic, or sort of all analgesic and opioid analgesic percentages over the kind of entire population compared with the Press Ganey population. We felt like it was clinically pretty similar to our overall experience, but we didn't specifically pull that out. And I think that would have been a reasonable thing to do. The demographics matched up pretty closely with what we had seen, but we didn't look at the medication administration.
Sure. And I, having worked in the community and have friends who are also medical directors, with their surveys, they're allowed to kind of automatically cut people out, people with psychiatric diagnoses or the diagnosis of drug-seeking behavior. Do you know if your shop has that, or?
With this particular, oh, sorry, I'm starting to echo. With this particular work, what we did was we excluded people who were there for anything other than their first ED visit. So we were able to see all comers, or all responses, I should say. But we specifically tied this to first ED visit. So if we had sort of overutilization during a short period of time or multiple bounce backs during a short period of time, we would only get one survey from that respondent. It's interesting, though. I think that when you talk about the ED directors, one of the things that comes up fairly frequently is the response rate again. And one of the sort of targets that you'll see with Press-Ganey is talking about your emergency department's results based on anywhere from a minimum of 30 to sort of the ideal of 50 responses in a given time frame. So, for example, I was looking at one of the bulletin boards in our little community hospital a couple days ago, and we had gone from 75% to 87% satisfaction in about a 5-month period. And when you looked at the 75%, there was an N of 12. And then somewhere in the middle, there was an N of 44. And then at 85, there was an N of 12. And I think that this concept of response rate is really a moving target when you talk about the smaller shops, so that, you know, that the selection bias really shows through when you're looking at very small numbers. And one of the things that I think Taylor and Meow Tai, who is our statistician, and Clay Merchant, who's sort of the epidemiology powerhouse behind this work, one of the things that they did extremely well was to pull in as many surveys as we could during the relevant time period, so that we had a large enough sample size that we were able to detect fairly small effects. And we just consistently, throughout the different analyses and the different questions on the Press-Ganey survey, really did not see any relationship between improved satisfaction and opioid analgesic administration.
Yeah, I think you hit the right. The main point here with the Press-Ganeys, you really captured really nicely in terms of it's all about the response rate, and I think that's what people kind of harp on a lot. And it's interesting, if Press-Ganey weren't so established now and they submitted these responses into, for instance, Annals of Emergency Medicine, would they have been published? There's no way, right? There has to be like at least a 70% response rate. It's just, it seems that there's this a weird double standard with all this. But if you put them up to journal standards, I think things would be a little bit different. But let's try to sum up here, and let's each kind of leave the viewership here with one lesson, teaching pearl you want to share with the group. Why don't we start with Kavita first?
I think that the horse has left the barn, and these kinds of surveys are they're here to stay. I think that there is some value in any sort of survey that reflects quality and the patient experience. I don't know if that's what we have here, but I think that we all have to be so careful about the impact that these surveys, these satisfaction metrics, compensation have on our care of patients, because at the end of the day, we took an oath. And in terms of doing the best thing that we can, I'm not sure that these surveys are pointing us in the right direction.
Perfect. Taylor?
I think that although these surveys are problematic, we do need to remember to focus on compassionate, patient-centered care and doing the best thing for our patient, and in an ideal world, not worrying about our scores. But I think that our study allows you to work in that framework that we're given, which is not ideal, and say that maybe you can give whatever you think appropriate and not be concerned about the effect on your score.
Great. What about Justin?
I agree. I mean, we've come so far from the paternalistic nature of medicine from World War II era, where we just told them what to do and they were just supposed to accept it. But maybe we might have pushed a little too far to the other side, where now if we're not giving them unindicated or unnecessary things, that it might be hindering people's either income or even job abilities. And it really came to a head in Texas when the DEA went to Schedule 2. none of the emergency providers were able to provide those prescriptions because our Texas Department of Public Safety has a special script pad that could prescribe that. And so suddenly we went from everybody giving Norco to everybody giving Ultram. And there started, and because of some other contacts, the Texas College of Emergency Physicians said that people were being told to get the script pads for patient satisfaction purposes, not for patient care purposes, which is I really think they needed to have before. But and this paper is a really great step in the first direction to try and get rid of some of the biases that people have against it, and maybe we can have a better discussion in the future about what patient satisfaction means and what these surveys are getting us the information of.
Great, and then we got Lauren to bring it home.
So I thought this was a really interesting paper, and it made me, as a resident, really think about ways in which I can impact patient satisfaction, or at least provide better patient care, because it made me realize that a number may be kind of irrelevant if I'm getting just a feedback as a number, and really addressing patient expectations and think about the other components that really may make a patient experience better in the emergency department, whether it's length of stay, as Kavita mentioned, or whether it's just education about, the dangers of prescribing opioids, or maybe why I am or am not prescribing something. So I kind of took a very personal message home from reading this study and being involved in this, about the limitations of looking at a score in terms of patient satisfaction, but then also just how to connect with patients and maybe make them a little more satisfied in that way.
Well, I couldn't have said it any better, so I'm just going to end it right there. And thank you guys so much for joining this video cast on Google Hangout on Air. And signing off. High five, everyone.
Thank you.